Okay. So this is a presentation that I made last week for the Right Care Initiative about hypertension, about controlling hypertension on populations at risk. And so it is a little bit technical in some parts. So I may skip certain things just to not get too technical. Um, but if you want me not to skip something, stop me. I'm happy to stop and drill down as detailed as I can explain things. So I'm happy to do that. And then hopefully I won't consume all the time on the presentation. Then we have some time for conversation discussion at the end. I actually have a question or two at the end to generate some conversation discussion. But the reason this is an important topic, and as you know, for over the years, I've been very interested on continuing to figure out ways to better control blood pressure and diabetes because they're such a driving forces of cardiovascular disease. And my sole purpose professionally is to slow down the progression of cardiovascular disease or prevent the consequences of it. And so that's why I continue working on this. And over the last few decades, we recognize that blood pressure is not only detrimental for us, but is also detrimental for certain people more than others. And so there are different groups of people who high blood pressure, it could be a bigger problem than others. And so the question is who they are. And so the first few minutes of the presentation is just starting at the United States level, just drilling down just a little bit down into subgroups of people and how they're affected by high blood pressure. And in that portion of the talk, I'll talk a little bit about why that it's important when I, as a doctor, or we in public health are trying to figure out how to help people, the people that are being affected. Because the better we understand the characteristics of the people being affected by the high blood pressure, the better we are at putting together an intervention, which is what we usually do in medicine to try to help people out. So drilling down into this is not just academic and esoteric, it's drilling down to understand the characteristics such that we're informed on how to build programs that can help people. So the first third of the talk, it's going to be about that. And then I'm going to shift gears a little bit to then talk about a program that we've been building over the last year and a half on blood pressure, better blood pressure management. And I think at some point about 6 or 8 months ago, Talia, who works with me in this program, made a brief presentation here about what we were planning to do. So we now have done it and we have some data. And so I'm going to share with you a little bit of what we've done to improve blood pressure control on a patient population. And the patient population we are working with is out of a clinic for patients who are uninsured. So the patients in our program are all uninsured patients. So they're kind of like that clinic is kind of the safety net for our healthcare system where there's some people that still have no insurance. And that usually translates into a lack of access to care, a lack of access to doctors and blood pressure devices and monitors and medications and things like that. So you could imagine they tend to carry the brunt of the consequences of high blood pressure if they don't manage it or they don't have access to management. So we're trying to break that barrier. That's a barrier, the lack of insurance, by bringing to them certain programs that can actually overcome the barrier of lack of insurance. So do I have a better way of doing this? Yeah, let's give them insurance. And then they have the same access all of the rest of us, I assume. I'm totally assuming that all of us here have access to insurance. So forgive me if I'm assuming incorrectly, but so that's one way of solving it, but no one has yet called me up to say, how can we give insurance to everyone? So instead, what we do is then figure out how to bring programs and build programs that can still deliver the care, meaning normalize the blood pressures despite people not having health insurance. And so that's what I'll kind of run through a little bit. I'll at the end, I'll show you a couple of questions we ask of people in this program and their answers. And I'm going to ask you what the answers will be if we were asking those questions of you. And just so we can kind of wrap it up as what can we have learned from this experience that could better your abilities to take care of your blood pressure. So big arc, see if I can get there. So let's see. So I have no conflict of interest to declare related to this. First, I'm going to review the low treatment success populations. That's what I call them. So this is the people we fail because we succeed poorly with them. I'm going to describe the use of PGHD, which stands for patient-generated health data. This means you generate the data, not the clinic or the doctor in the hospital generates the data that we use to then implement what we call an equitable hypertension program. And it's equitable because we figure out what people need and then we give them what they need such that they can have the same result. So equitable means you have to understand the characteristics and the needs of individual people and groups of people, and then you correct for their deficiencies such that they reach a declared result. Here, the declared result is to normalize blood pressures, nothing else. And then I'll end with some lessons learned from the program and some questions like I mentioned. So why is this important? And this is, to me, today still the single most important graph that I look at all day long. And you've seen it in many different ways because I talk about it all the time, and it just really kind of justifies why I do what I do every day. So let me show you what this is on the y-axis or the upright axis. We're looking at death per 100,000 people. And so high number is bad, low numbers are good. And then starts in 1965 all the way to 2020. So 35 plus 20, about 55 years worth of data. And what he shows, and then the blue color are the males, the orange watermelon color is the females. And what I want you to see is that for the latter part of last century, there was a decrease. But if you notice here, right around 2010, it stopped decreasing. So we have hit a wall. We're no longer decreasing the amounts of death due to cardiovascular disease. Now, I can tell you, all my colleagues at UC Davis can tell you, we've only got better at treating cardiovascular disease in the last decade. And in fact, you know, all my colleagues give amazing talks about the amazing things we can do at UC Davis. But when you look at the entire population of the United States, we're not changing the course of cardiovascular disease. That's a problem. In fact, I can tell you that in the last 2 years, that curve is starting to go back up. And we can talk about that in the Q&A if you want to. So when I think about this, I said, okay, well, what are the things contributing to cardiovascular death in this country? And I'm going to break it down in 4 groups. Again, this is death per 100,000 the population. A higher number here is more deaths is worse. And so we'd like to see things going down. And that's what you see on most of this curve. So as you go to the right, they're going down. The blue circles are heart disease, specifically to heart. So first was cardiovascular, which includes all the things other than the heart. This is just the heart. And again, you see the downward, this is only 2000 to 2018. So this is a short amount of time, but you see the decline. And then here's the 2010 mark where it's flattens out. Here's for stroke. We were doing well on stroke until about, again, 2010, and it flattens out. That means as the year goes by, the same amount of people per 100,000, so it's a fraction, continues to die. So whatever we're doing is not making this number go down. And ideally, as we get better to improve the population, these curves ought to come down. And there'll be a moment where we, quote unquote, won't be able to get any better, but we don't think these are those places. We think we're still way up above the levels where we can prevent things. But here's diabetes. Diabetes wasn't really going down. So we really weren't doing that great in the last 20, 30 years with diabetes. And here's hypertension. Yes, per category, less people die of only hypertension. But hypertension has been a flat line the entire 20 years. That means nothing we were doing the last 20 years have changed the amount of people that actually were dying from just hypertension. Now, I'll remind you, hypertension is a contributing factor to all 3 of these. So this is the people who died just due to hypertension, okay? Because all of these people, there's high numbers of these people had hypertension and they're combined up here. These are the people who just have hypertension and die from that. So this is a problem. And in fact, if it wasn't because of the way the curve is, this line even looks like it's maybe actually tilting up a little bit, the green line. So it's not only we weren't making it go down, it actually looks like it wants to kind of take off, which is a problem. That means hypertension, high blood pressure, is the most treatable condition of all 4 of these. I know how to take care of hypertension much better than I know how to take care of heart disease as a big bubble, stroke, and or diabetes. But it is the one that we do the worst. This is why I spend time doing this, because this curve needs to be going like this. And that's our goal. Now I haven't told, this is for all Americans so far, US, in the US. This comes from CDC data, epidemiological data, based on death certificates. So people went back and looked at all the death certificates of people who die in the United States and figure out these numbers. Now, what about populations, groups of people that are heavily burdened with this reality over others? Because so far I haven't told you anything about individual groups of people. So let me just expand just the hypertension line into a graph over here. So I'm not going to peel off these and forget about them for the rest of the talk. I'm only going to talk about hypertension. And I'm going to show you this new graph. Now, it shouldn't take very long to know that there's two lines that are almost on top of each other in the bottom of the graph, and two lines on the top of the graph that are fairly parallel to each other, remarkably away from the two on the bottom, a little bit off from each other. So now let me tell you who they are. The blue circles on the top are Black men. The purple triangles here are Black women. The pink squares here are the white men, and the green triangles are the white women. There's no way where you can think this is happening, the same thing is happening to all four of these populations. They are so different. Black versus white people, remarkable difference on the death up here in the curve. And then when you look between men and women among Black people, the men are worse off than the women. When you look within the white people, the men and the women are equally well off or worse off, whichever way you think about it. So that's the first observation. The second observation is that it's been flat for Black people this entire 20 years. Meaning nothing we've done has changed that curve. But here's the part that I'm hoping somebody gets alarmed about. The curve for white people is going up. We can talk about why I hope somebody gets alarmed with that, because hopefully we'll get attention to this condition as a big problem. So this is, remember when I said here, it looks like it's almost going up? Well, it is. It's actually going up in these two subpopulations. It's been high for so long on this population. They're fairly flat. So this is what I mean. It's only until you start breaking down a big pot of people in the United States into subgroups that you start realizing this is not the same condition, same situation as these people here. And what happened to this group here is not the same what's happening here as it's happening here. Something has changed over the years for this group. Something between these two groups is different. There's so many questions to be answered here. If we're ever going to take all four of those lines and make them go down, which is what we want to be. We want to be doing this on four of those lines. That's how we want the next 20 years to look like. So we want those four lines to be doing this. We better hurry up and start coming up with better ways of managing blood pressure for everyone. But I can tell you, the way we manage blood pressure for these different groups is going to have to be different, because these are different people, different realities, different worlds, different conditions. There's so many components under that word different that needs to be unpacked such that we can build the intervention programs. So what's different here? Well, I'm going to argue with you, it's the health disparities. That's what makes it different. Is what's a so-called new word in town, which is the social determinants of health. So it's poverty, it's stress, it's crime, it's lack of access to insurance. That's what we believe is kind of creating this huge gap. And then it's lifestyle. And these things are not isolated, they're intermingled with each other. So if you have no health insurance and you live in a neighborhood where there are no sidewalks, or it's not safe to go out on the streets, then of course you don't exercise. Lack of exercise leads to high blood pressure. just so you can start painting a picture in different ways based on the neighborhood, for example, that somebody lives. So what's the solution to that? Build sidewalks, make neighborhoods healthier, safer, and then educate and encourage people to engage in more healthy lifestyles. So that would look different depending on which neighborhood you live in, or depending on what you lack in your neighborhood. So you see, it's not about the individual people, it's about where we live and the environment in which we're exposed. And that's kind of what we've been learning in the last 10 or 20 years, that really that's the part we really worked really hard to make big improvements and better medicines, and very expensive ones, by the way. But we're not really paying attention to these other factors yet so clearly. So part of this presentation is to make us aware that it's not just about medicines, it's about these other things that affect people. Now, as you all know, I'm Latino and I have interests on Hispanic and their outcomes as well. So I look for data comparing. So that was comparing subgroups of men and women, Black and white people. This is now looking at Hispanic and non-Hispanic white people in the United States. This is the data that's available. It's the same data set. It's just published differently and analyzed differently, but it's actually the same data set from the CDC, from the death certificates of the CDC. Same arrangement. On the upright is the death rates, and then time across in the bottom line. Death and then time across. This is now showing the difference between males and females on the right side. And then the orange line is the non-white, non-Hispanic white. And then the blue line is the Hispanics. And so what we've been saying is things are going up. This is hypertensive, by the way. This is hypertension. Just focus on hypertension. And just like I show you that green triangles, and then the line here it is again in this data set going up again. Like I pointed out for the non-Hispanic whites, it was going up. That's what I showed you in the prior graph. Well, here's what's happening to Hispanics. It's also going up. Maybe at a little slower rate. That's why the blue line is just a little bit below the orange, so not as fast, rising as fast, but it's still rising in men and women similarly. Now, what about based on age? So these are young people, less than 45. These are seasoned people between 45 and 64, and these are the wise people older than 65, okay? And so for the most part, it's going up for everyone. But for the younger people, the non-Hispanic whites are kind of accelerating a little bit. The Hispanics are lagging a little bit. Same thing for the 45 to 64, but the older than 65 is the same gig, same situation, equal, no difference. So again, this is a situation that is affecting all the major populations. I apologize, I do not have data on Asian ethnic groups. It just wasn't, it's not published or available in this data set. I know that there are distinctions among Asians, and it's actually interesting that they're mostly affected by stroke than they are affected by heart disease as a population. And then there are different subgroups of Asian. There's South Asians that really get affected by heart disease over stroke. So every time you drill down one level of subpopulation, you unpack a remarkable amount of heterogeneity and differences among them. And then you got to keep trying to unpack and understand. This is why I'm going to be busy doing research for a long time. Now, a specific population. So a lot of people think Latinos we're all the same. We're not. This is a comparison between Mexican Americans, Cuban Americans, and Puerto Ricans, which is what I am. And I can tell you that everyone in the Latino community knows that I am a Puerto Rican just the moment I open my mouth. So I'm different just by opening my mouth. The way I speak Spanish is like, el doctor es puertorriqueño. So we're remarkably different from the get-go. And so this is intended to try to understand how high blood pressure was affecting, and what are the factors that are related to hypertension affecting these three separate groups of Latinos. It's a complicated graph. I've made some boxes to kind of focus on some things here. But this is, again, age-adjusted prevalence of hypertension. Prevalence means how many people, if you counted everyone all at once, how many people actually have the condition. And so if this is Mexican Americans on the top, Cuban Americans in the middle, Puerto Ricans on the bottom, and then it's broken down men, women, men, women, men, women. So I'm only focusing on the Mexican American men, and I'm going to compare them to the Cuban American women. Okay, so those are for the sake of conversation and to keep us focused here. So the prevalence means what percent of these two groups of people have high blood pressure. 22% of Mexican American men have high blood pressure. 13% of the Cuban American women have high blood pressure, fairly similar amount. But look at their awareness. So out of the 22% that have it, what percent of them knew that they have knowledge? Only 40%. Of the 13% of women, Cuban American women that had hypertension, what percent of them knew that they had it? 91%. That's so powerful, and I'll tell you why. So if I wanted to put together an intervention to help the Mexican American men, I would work on awareness, because there's a 60% of these people walking around don't know they have high blood pressure. So by getting awareness, I may be able to get better control of their blood pressure. Start with awareness. But if I came to the women and I started with awareness, I'd be wasting my time as a public health intervention, because 91% of them was like, I'm bored. I know this, doc. Why are you telling me about this? So what I need to work with then is on treatment. How do I get better treatments, or what other things, lifestyle, what other things are keeping them from, despite being aware, from getting control of their blood pressure? So you see, understanding the characteristics of the subgroups is what helps us build the intervention. So make no mistake, there is no one solution to all. So it just doesn't work. That gender difference, it's not universal. So there are gender differences for specific conditions, and there are some gender differences that are not. There are certain conditions to which there are no gender differences. And gender and sex are two variations of the same, it's the same concept and needs to be looked at separate. Gender versus sex. So sex assigned at birth is what I mean. Right. So just in general, men are more clueless regardless of. Yeah. Oh, about that one. I'll take the fifth on that one. I'm clueless about that. So anyway, this is to elaborate more on the point of treatment and control. But I have a lot more I want to say, but I just wanted to make the point. So if you start looking at sex, different groups, and what they know and what the treatments they're taking, how much, then you start learning and figure it out how we can better put together a program for them. I'm going to elaborate a little more of this. I thought this is very interesting. So now it's looking at overweight and high blood pressure, because being overweight or obese combined with hypertension. So as we gain weight from unhealthy lifestyles, mostly, our rates of blood pressure go up, and then both conditions start going up. And the combination of the two is what leads to the heart disease and the complications that we see with obesity and hypertension. I want to make a pause for a second. Just because we're large people size-wise does not make us unhealthy or just obese. There are some people who are just larger, but you can be large and healthy versus large and unhealthy. And in medicine, we're still trying to tease that out. If you read the news, you heard about the BMI, how there's a big debate now whether BMI is good or not, about telling us whether we're obese or not. It's actually probably not very good to tell us who's healthier and who's not. It just tells us we're bigger or not in relation to our height. That's all it really tells us. But it's been used for a long time. So there's a lot of data, a lot of information out there with it. We have to learn how to live with this metric, but it is not a deterministic metric of, oh, your BMI is 34. Boy, you're obese, you're doomed. No, there could be a lot of people with BMI 34, 35 who are large, but are very healthy. And it's just hard to, obesity implies that there's something medically wrong with you. It's a disease, a diagnosis. Medicare pays for the treatment of obesity. So it's treated as a disease, but it really is not. It's, anyway, today we're not talking about obesity, but so this is focusing on the women now for the three groups. So 41% of these women had were overweight. Actually, it's not obese, it's overweight, versus 31 versus 40, roughly about the same. It's a little different between the Cuban Americans and the Mexicans and Puerto Ricans. And then the question was, out of the obese people, what percent of them had hypertension? Well, the Puerto Ricans have a lot less hypertension with their obesity than the Mexican and the Cuban Americans. So if you look now at smoking over here for these groups, so you got obesity, hypertension, and smoking. Obesity, hypertension, and smoking. Obesity, hypertension, smoking. So not a big, huge difference between these three groups here. So the women across are fairly similar to each other. Now, what about the men? Well, the men are remarkably different. Men in all three groups smoke a lot more than women in all three groups. So again, if you want to help the men with obesity and hypertension, you want to think about smoking programs as well. I'm not saying that the 23% of women who smoke don't need attention. I got to be careful about this. I'm thinking at a higher level about putting programs that I can improve and affect a larger amount of people at any one moment. And so then this is how you start trying to focus on the group characteristics to put together programs. And so you would have programs for smokers addressing to the males, and you would have programs for smokers addressing to the females. But when you're trying to maximize who do you help first or the most at any one moment, you want to make sure that smoking is a big component of the male program, where you would want to find out what other things are contributing to the women and then work with them on that. So if you look at obesity, the women tend to have more obesity than the men. So you would work on probably on the obesity focus with women, work with the smoking focus with men. You don't exclude them, you just kind of focus so it's what affects them and then try to grab their attention because it's what's happening to them. How big is the problem of high blood pressure? Notice that I didn't say that at the beginning. How many people are affected in this country with hypertension? Any guesses? 100% of adults? What fraction, what percent of adults in America are affected by high blood pressure? 60. Do I have a better or bigger or lower bidder? 70%. Okay, wow. I've made a good impression on you guys. So let me correct that because I may have made more of an impression that I wanted to. It's only 45%. So if you look at it, it's still too much. That is correct. If you look at it, it's 108 million people, adults in America, walk around with high blood pressure. That's a heck of a lot of people. And so it is by far one of the largest problems. Smokers are much smaller. Diabetes is much smaller. Hypertension is like the biggest of all of them. So let me give you a little bit more information about them. So 4 out of 5 of this 45% know that they have hypertension, and they've been told to do something about it, lifestyle, or take prescription medicine. So that's 87%, 87 million of that 108 million have actually been told, heard it from a doctor. It's on their record somewhere. They have hypertension, and it's somewhere on the record says that we're given a medicine, or somewhere on the records says that they were asked to exercise more, cut down on salt, deal with stress, because about a half a dozen more lifestyles there that we could look into. So, but what percent of that is actually control? The flip of that, only 3 out of 4 are uncontrolled. So only 1 out of 4 are actually controlled. So of all the people who've heard something about it, only 25% of them are controlled. And then 1 out of 3 are untreated. So there's a group of people that even though they have it, they've never been given anything. There's no documentation anywhere that they've ever been given a medicine and are told that they need to quit smoking, exercise, eat healthy. So are you confused yet with these numbers? Because I was. So what I'm doing is I'm going to digest them for you. This is the number I want you to remember. When you look at the amount of Americans who have hypertension and whether they've been told, take the medicine, control this, that. But bottom line is, it doesn't matter that you have high blood pressure. The question is whether your blood pressures are normalized. That's what matters, that the numbers are good. So you can have the big title of having hypertension, but as long as your numbers are good, hypertension is not hurting you. And that's what I want you to remember. Your numbers are normalized, and it doesn't matter you have this. Don't go home and worry about it. It doesn't matter. The numbers are normalized. You're good.
So you're saying if you're on if you've been labeled hypertension, but you're on medication, you're doing, that's fine.
And your numbers are on the 130/80, which is the current cutoff we have.
So that 130/80, is that age?
Less than that. Not, we can talk about age on the Q&A. Q&A makes things a little murky, and you have to know the backstory behind age. But the short is age is not a factor here. So if the older you are, you still benefit from a lower blood pressure. So there's nothing that denies you the right of having a lower blood pressure the older you are.
No, because I have heard that.
Yeah.
It doesn't hurt if you're older and your blood pressure is a little higher, that is okay.
Yeah.
That's fine.
Yeah, it is. There are a lot of details in that statement.
Okay.
And so I'm happy to go over those in the Q&A, but it's a good question because you will hear this from your own doctors in the office and from your friends that, oh, they told me I can have 140, or they told me it's okay, I have up to 150, I don't have to take any medicine. This is common. You'll hear that, but we can talk about it in the Q&A to unpack that. But what I want you to remember is only 16% of Americans have hypertension and are well treated. So these are the people who should feel good about themselves, about what's going on to them. The other 84% of this 100 million need to worry about this. You know, that's the target population when we talk about putting programs together, is that other 84% of people, of that 100 million people. That's a lot of people out there that still need some help with the blood pressure. It's just still a big problem. Okay. So I'm going to talk to you now about this program. So I just finished describing populations, subpopulations, how big the problem is, and why is it that we still need to, put programs together. This work was funded by the California Department of Public Health with money that came through the CDC. It's part of the funding that paid for me to come here for the first 3 years. I don't get paid anymore to come here. I come here because I have fun with you. But initially the grant that paid me to start doing this work. And so we put together this program. So how many of you have a high blood pressure machine at home? Okay, most of you. How many of you have had to struggle with the machine because it doesn't work, have the numbers, the thing doesn't fit? Sporadically, one of you. How many of you have struggled getting those numbers to your doctor?
Yep.
Getting the numbers to your doctor. How many of you actually tried to get your numbers to your doctor? Give the doctor the numbers so they can help you with the treatment of blood pressure, or just to make sure your blood pressure is okay.
I just go to the doctor's office, but when I have a regular appointment, they check it.
And they check, yeah. But you don't check it with a device at home. You don't have a home device that you check it. Those of you that have a device at home, do you ever try to get those numbers to your doctor?
Yeah.
Yeah. And how often do you have a challenge with that, a problem or a difficulty?
It's no problem because you just go online and you put it in.
Beautiful.
Then, yeah, then if
So you have a portal and you go in the portal
Right.
and you type them in, and
if she questioned it, then she said, come on in and let's check it here.
perfect. So your doctor can see it and then questions you and then say, hey, this doesn't look so good. Come in and let's check it out. Okay, great. That's a good experience. That's great.
You're actually typing them.
But you're typing in the numbers
yeah,
yourself,
yes, yeah.
right? Right. So you take it, you write it down, but do you give them the date and time?
Yeah,
or-
I do, when she, I take it maybe, I used to do it once a week. She said it's not necessary to do it, every day,
Mhm.
maybe 2-3 times a week.
2 or 3 times a week. Yeah,
Right.
that's good.
And then I just write it down in an email and send it to them.
Perfect. Got it. So anybody else want to share their experience? Yes. Amran,
battery.
Yeah, yeah.
Anywhere from 182 to 196.
Oh, wow.
And over whatever, 92, I think, it was
Mhm.
last night. I could hardly sleep. I come in here purposely at 9:15 to have my blood pressure taken.
Yeah,
It's normal.
normal. Got it. Yeah, yeah.
So, I can give that.
Don't give it away yet. There, yeah, there's something you should do about before you give it away. And I can talk with you about at the end, what to do before you throw it away. Don't throw it away yet. At home, okay?
Because, someone did buy a printout,
Uh-huh,
and I have taken it several times to different doctors. So
got it,
It's wonderful to have that
got it.
convenience.
Okay, that is wonderful. Anybody at home wants to say something about this? You don't have to. I just want to make sure that if somebody wanted to, they have a chance. Okay, so that's great. So you guys have actually written the rest of my talk. So, but before I give you the rest of the talk, which gets technical, and I'll skip a bunch of stuff just to make sure time-wise, we're not here until midnight. What time is it? 12:53? Oh boy, I better stop. I better just talk with you now the next 10 minutes and not worry about the rest of the talk. But let me explain to you now what you just described is a good experience at being able to acquire your information for your blood pressure and deliver it to the doctors at some way or another. And each one of you have figured out some way of managing. You're still managing whether the machine is good or not, and I'll help you with that at the end. But I'm glad. It's great to hear that. Now, let me tell you what my typical patient in my clinic, where we put this program together is. First of all, they don't know English. 75% speak not a word of English. So most of them have a phone that they can text. They have no idea what a portal is. They have no idea what Bluetooth is. They don't understand Wi-Fi. They can't even connect to Wi-Fi, Bluetooth, because they don't have Wi-Fi because they can't afford it. Your devices probably have 3 buttons in it, has a little, Bluetooth little thing to it, has an arrow to go up and down, this and that. The moment I put 3 buttons in front of them, they're not sure what to do with the 3 buttons. It's not because they're not smart. I want to be careful about this. It's because it's novel. Whenever somebody put new technology in front of you, the first time your family member brought you an iPhone and put it on your hands, and you were like, remember that moment? That's what it is when I show them a machine that has 3 buttons in it. And all these numbers, and there's 3 kinds of numbers, and one's on the top, one on the bottom. So their understanding of this, because they've never been quite exposed to it. Here in the United States, every time you go to the doctor, they check your blood pressure, you go to once a year, this and that. Some of the patients I take care of didn't grow up in this system. Even if they live in this country, they don't actually have access to a doctor. They haven't seen a doctor in 5 years, 10 years. So they only see a doctor when they're really, really sick in the emergency room. So they don't know the pattern of checking blood pressures regularly and the pattern of seeing it normal. Oh, let's have a conversation about being up, which we have experienced. They have none of that in their background. So then I walk in the door and we see them in the office for a sore throat or something, and their blood pressure is 180 or 110. And they have no idea what that means. They have no background information. And I said, now you have to go and buy a machine that's $40. You don't have $40 to spare. You barely can make a meal for $6 or $7. So $40 is going hungry for about 5 or 6 meals. So one more challenge is the cost of the machine. So I can keep going because the list of barriers is about 18 or 19 of them. My students listed about 18 or 19 barriers that our patients have to ever get to the point where these patients who have not a consistent doctor actually can show a list of blood pressures to a doctor they don't know so that they can get medicines to take care. So our goal was to break as many of those variables as possible with as simple of an intervention. And the answer to it that we've come up with is this patient-generated health data concept where we have a device for the blood pressure where it has one button. No more buttons, just a single button. So even if you cannot read the machine, all you got to teach people is you put this thing on your arm this way and you push the one button. It's a two-step process. That's it. That's all they have to do. Put it correctly on their arm and push the one button. And the machine has a cellular chip in it. So the cellular chip sends the signal up to the cloud, puts it on a dashboard, and then whenever I want, I go and log in on the dashboard, and there is patient number one. We don't even have their names on it. It's a fully anonymized process. So it doesn't matter, they don't have to have the fear. So the other fear that we don't usually worry about, and we, again, I am assuming that I know all of you and that all of you are like me. So I apologize if that's not true. But is that we all feel like we're okay in the system. A lot of my patients don't feel like they're okay in the system. The reason they don't go to the doctor is they're afraid they're gonna get picked up and put in jail or some variation of it, or deported. So that's why they don't even go to the doctor, okay? So they don't wanna give me the phone number. They don't wanna give me any addresses. They don't wanna give me any personal information for that reason. So what do? We build a system. They're patient number one, patient number two, and patient number three. And so I have no information, no personal information of them in this program. So they can have access to their dashboard if they want it. We give them the password to it. They can see if they have the ability and the knowledge, they can go in and look at their own blood pressures. Otherwise, we review them every 2 weeks for them, and we text them. Send them a text. All is good. Keep going. And they get in Spanish, because most of them are Spanish. 25% of them are English speakers. It's only 74% Spanish. So they get a text message and they get encouraged to keep doing what they're doing because their numbers look good. Because remember, the bottom line here is to normalize the numbers. So if the numbers are not good, then we start asking questions through text. Are you okay? Is there any problems that happened this past 2 weeks? Yeah, everything's good. Did you run out of any medicines? Is that lack of medicine? And so we got a couple of questions we asked by text, and then if we cannot figure it out in the first 2 to 3 text questions, why is it the numbers are high? Then we schedule a phone call with them, and then we talk to them. We say, what's going on? What's different? A month ago you were doing great. Now it's not. What's going on? What's different? And then we start diving into what may be different to that blood pressure. This program that I have, we have currently 26 people in it. So I'm going to run through the slides really fast, but I'm not going to go through all the details of it. But I wanted to explain to you what the program is. So I got rid of all the language barrier. I got rid of all the literacy issues. I got rid of all the cost of Bluetooth and Wi-Fi and all that. They don't need to have a phone. They don't even need to have a phone. I mean, we like them, and in reality, everybody has a phone. So we can text them, so we can connect with them. But they don't need to have a phone to actually have their blood pressure measured. So you can have a great machine that's Bluetooth, but if your phone doesn't work, you can't make it work. We give them the machine. So the grant from the health department allowed us to buy the machines. So I was told, what are you going to do with these machines? I thought, you're just going to give them away? You're never going to, how are you going to sustain that, Dr. Lopez? You're just going to give machines, you'll never see them again. In fact, how do you know these patients aren't going to even come back? You're going to waste your money and time. We've given 27 machines away. Every one of them has returned except one. One patient that we've never been able to find them again. Don't know where they are. Every one of them returned. Every one of them came back with a smile and a thank you, actually. And then because we give them a machine for 2 weeks, because we do a screening at home for 2 weeks. We give it to them, say, use it for 2 weeks, bring it back. My students will take the data out of the machine, so the person doesn't have to do anything with it. And I'm going to show you a graph of that. And then we decide that they actually have hypertension at home. This is an issue, whether you have it at home or in the office. And then if they have hypertension at home, then we give them the cellular device. The first device we give is it's not $100, only $40. And it doesn't have a cellular, but it has a memory in it. And so we are able to get their numbers back and determine. And we did that because if they never returned the first one, we're never giving them a second one. It was kind of save some money, safety component. But every one of those first one we gave, every one of them returned. So we were like, okay, this may actually work. So we've discharged 9 patients already from the program. Everyone returned their cellular device. When they were done, they brought it back and said, thank you so much. God gave us a device back. So now we're enrolling new people and we're giving them the devices. So we bought 25 devices and we're going to be able to take care of more than 25 people with, because we have a loaner program. So we build a loaner program. That's how the program runs. Let's see. So what are the challenges of doing office? So this talk starts by saying office blood pressures are not that great. They're actually very much all over the place. And there's white coat hypertension, if you have heard of that. There's a thing called mask hypertension. There are all kinds of inaccuracies with the office blood pressure. The best blood pressures are the ones you measure at home. That's the ones that tell us the best how healthy your numbers are in relation to your body. So there are many, many challenges with home blood pressure. This is mumble jumble lettering that we deal with in academics about all of this and what other just patient-generated health data. What our program is the patient home device. And then we ask them, we teach them how to sit for 5 minutes, take a deep breath and have happy thoughts. Not a hard thing to teach people. And then they hit the button 3 times. And we teach them in the office. The first visit they come to the office, we sit with them. We actually have them sit for 5 minutes. And we teach them how to time themselves and push that button 3 times. Click, wait for a minute, hit it again. So that means I get 3 numbers with a date and time stamp on the dashboard. It's all automatic. And then I know that these 3 readings were done together because they're a minute apart. And I am so impressed. I'm going to actually publish the minute variation, and you'll see how actually people follow instructions beautifully. They're almost always within the minute. Sometimes it's 2 minutes. That's about it. It's not like one now and like 20 minutes later, they got another one. They sit down and get this done as they were taught and instructed in the clinic. I am blown out of my mind because about how responsive this population was to that. So the question is, and this gets to the point of why the home blood pressures are better than the office. So this is the comparison of office blood pressures at home for 1 day, blood pressures at home for 2 days, and then an average of all the blood pressures at home versus what's called a 24-hour ambulatory machine. That's the machine you wear on your arm for 24 hours, squeezes you every 30 minutes. If you have had that, it's great. It's the best. It's the gold standard. It's really annoying because it squeezes even through the night for 24 hours while you're sleeping. It's squeezing your arm. So that's the best for its relationship to your heart and your kidney function. This is heart, this is kidney function. The 24-hour machine is the best. Well, the second best is just doing home measurements and averaging them together. And so that's what we're doing. We're doing the average of the home measurements for 2 weeks to make the decisions. And we know that that's a pretty, so that it's a very good correlation whether your heart is suffering from the blood pressure and whether your kidneys are suffering from the blood pressures. It's almost as good. And this is for systolic and this is for the diastolic here. It's almost as good. Look at where the office number is. It's way down here. So you almost double the benefit by doing it at home. It's just a little technical data just to say that the home is the optimal way of measuring the blood pressures. This is the details of the clinic that we're doing. And I've already told you just about everything that's on that slide. Our project was to implement the remote patient monitoring program, self-measure blood pressures. People do it themselves. And weights, we gave them a weight balance as well. Using cellular devices, and then we use a web-based anonymous interface for patients to share their generated data with the provider, which is me. This is our workflow conceptual model. We did a screen of 212 patients in this clinic. We came up with 61 patients who met the criteria, and we started working with 32 patients, and we have 27 patients who completed the screening already. This other group here is still in the process of being screened, being contacted and being enrolled. So question to you. If you measure your blood pressure, do you keep a log?
Well, most of those machines keep logs.
That's right. So that you electronic, so you have an electronic log. So we ask our population, if you measure your blood pressure, how many of you keep a log? Only 29% of them. So 71% of them don't keep a log. They didn't even realize they actually needed to. You detect the number and they walk away. They don't actually keep a record of it. So our program keeps the record for them. They don't have to learn how to keep a record, don't have to do anything different. So there's not a barrier here to involve in the program, but the data now makes it to the doctor. Okay, how often do you check your blood pressure? So those of you that check your blood pressure, you do it every day, about once a day. That's actually once a week, it's supposed to be. About once a month, rarely, never. Who does it every day? Those of you that have blood pressure and a machine, any of you do it never? With the machine at home? So this is what our patients said. So 30% of them did it every day. Probably the same 30% that kept a log. Everyone else is such a mix. So people said 35% of them said about once a week, 18% once a month, and 18% said rarely. So this is not bad. People know that they should be checking their blood pressures at home at different rates, so we have to teach them how often to do it. Like we tell them, we sit down with them, we give them a calendar, and we talk about their work schedule. They all work. Some of them work 14 and 18 hours. I have a woman who at 5:30 is out on the street, doesn't get home until 10 o'clock from work. And she had the worst, I'm going to show you tracing. The worst blood pressure we found on this program was hers. And so she could only check her blood pressure at 5 in the morning. Because she said at 10 o'clock when I get home, I'm so tired, I can't even remember that I have a machine. So I said, okay, so you just give us blood pressures at 5 in the morning. That's the only, and so we would write it on our calendar with her. We worked out based on their schedule, the times. We usually like to have 2 blood pressures in the day so we can capture the morning and the midday. So our students work with them, build a calendar for 2 weeks for them to take the blood pressures and the times that they agree that they think they can do it. So they drive the determination of when they check the blood pressure. It's not the doctor, it's the people with their own schedules and their own realities. And so this just goes over the criteria. These are our 23 patients. So the average age is 59. It's 57% women. We have 74% Latino Hispanics. We have 22% African American patients, and we have 4% Asian background patients. And then 74% of them speak Spanish, and 61% of them have finished in the enrollment process. So they're in some, we're managing their blood pressure essentially at this point. This is this patient. So this is blood pressures in the axis here. Every one of these dots is a measurement they made at home. The dash lines tells you the bottom dash line is the normal. There's 0 blood pressures in the normal. All her blood pressures were actually hypertensive, except the first day. Let me show you some arrows here. So this is the average blood pressure in the office. It was 178 on the average in the office. We gave her a device. The first day, it was just elevated. It was almost normal, actually. So, but that was one day. This is probably her day off, by the way. That's what we think it was. And then here's every other day she's at work. So the average blood pressure for her, it still was in the 158, I think is what it was. That's what this time is, the average of all of them. So this is terrible. This is a middle-aged, working, productive woman who is going to have a stroke or a heart attack or something the longer this goes on. This is her diastolic blood pressure, same concept. She's in the normal, only that one day she has some normal measurements. So this is her beginning. This is what it is now. In fact, she's just got discharged from the program. All her readings, more than 50% of her readings are below the line of 120. 120 is not 130, it's 120, which is truly normal. And her average is just 127 or 128. So she is actually, no, I'm sorry, it's 118 here. So she's completely, we normalize her blood pressure completely on 2 medications.
Can you document the strategy that she uses or what she's been doing to lower it?
Yeah, so we talked a lot about lifestyle. We don't have all the answers of what she does lifestyle. She still works terribly. It's taken us a month and a half to be able to talk to her, again, because of her work schedule. But we know the medicine she's taking. So yes, so we prescribe the medicines every 30 days. And she's on 2 medications. We've adjusted the medicines to fit her work schedule. And so she's normalized her blood pressure. So this is success in our program. And so this is her diastolic blood pressure. We normalize them all. They're all normal. This day probably was a rough day at work. And she had a few that were close.
But she's motivated to take her meds.
She's motivated to take care of it. That's right. That's right. No one who's not no one that's not motivated benefits from any of this. Now this is overly technical, so I'm gonna skip that. This is just to talk about this mask hypertension that I was just saying, and this is the white coat hypertension. So the white coat people are the people that in the office have a high blood pressure, but at home they're normal. The mask people have normal blood pressures in the office, but when we give them a device, so about 5 people on that list, 23, they had normal pressures in the office. We gave them a device, and at home they're high. So that's mask hypertension. So those people are at risk because most of the time they have high blood pressure, but we missed it in the office. So that's why we like to do the blood, not just because it's a better representation of the damage to your organs, but because we can miss it if we just rely on the office blood pressure. This is an example of the mask hypertension. So this person on the office, he or she, I don't know who this was in the elevated range, but when we did the average of their home, they fall in the hypertension range, 140, 138 there. So that's the mask hypertension. And this is the white coat hypertension. In the office, they were 150, but when we did the home ones, they fall in the elevated range. So this wouldn't require medicine. This requires medicine. This doesn't. This requires lifestyle modifications. And so this person, instead of getting prescribed medicines that will give them lightheadedness and dizziness and side effects, because in reality, they're not hypertensive, we just talk to them about exercise, nutrition, and de-stressing. So again, this information helps us choose what we're going to do for them. So in summary, if we want to understand the trends of hypertension, we need to start disaggregating factors affecting mortality among subgroups. So what is different from the different groups? It's what we need to be learning about more to be able to figure out how to best help the people based on their challenges. So critically important because the different subgroups have different characteristics, most likely different root cause to their still unreached control of hypertension. So we should not assume that people have high blood pressure that is uncontrolled because they're not doing what I tell them to do. This is what I try to teach my fellows in the clinic. We should start thinking about where is it that we have failed to learn enough about them to actually help them build a plan that gets them a better blood pressure. Because I can tell you I got good medicines that can do this, and I can tell you a lifestyle works. And if you combine the two of them, there's almost no one out there that cannot be treated blood pressure. I have 2 patients that I still can't be able to control their blood pressure. And this is why I work hard. It's just still trying to figure out what to do for them. That's 2 out of my eyes in a month probably see over 1,000 patients. I have 2. So it's a really rare occasion where we don't have enough in our usual toolbox to help people. So what did we learn? So we learned the cellular technology. It's going to change how we do this. I mean, it's just so stupidly easy that it's like, once you try it and you use it, why would you not want to have a cellular device? It's one button. You got to just put the thing on, push the button, and the data is in the eyes and the hands of the person that can give you the feedback that you need. So it's incredibly simple. Reduce the patient burden. It increases acceptability. Every patient is doing it. We have 1 who disappeared out of the 26 in the group. It reduces the provider burden. I don't have to be calling people. My staff doesn't have to be transcribed. We get photocopies. We get pictures of handwritten notes of people's blood pressures. Now somebody has to sit there and type them into the computer in a chart. We don't, the burden to the providers goes down. Less of the nurse time, the pharmacist time, and then reduces the barriers, access, lack of appointments. No one needs an appointment to have their blood pressure checked. They're checking it at home. Transportation, no one has to come into the office to get their blood pressure checked. Language, it doesn't matter what you speak, just push one button. Literacy, you don't have to read the numbers, just push the button. Loss of work, nobody has to skip work to get their blood pressure checked. Put it on the purse, take it with you, push the button. Caretaking burden, no, you don't have to get your family to chase you around to write the numbers down and get your daughter or son to be the ones that then sends them email to the doctor. None of that stuff. All of that goes away. what are your barriers to normal high blood pressure? And then the presentation is over. Now it's just an open conversation. Any questions or thoughts you want to converse some more about? Yes. Yeah.
In 1980.
Both of, say that again, both of,
Children as teenagers had hypertension. And this was in the 1980s. Mine didn't show up until I was 45, when my metabolism and hormones changed.
yeah. So there are genetics, but it's, they're called secondary causes of hypertension. There's a small, maybe about 1 to 3% of people have an explanation for their high blood pressure, which is not just high blood pressure. This is all about people who have just high blood pressure, which is 97% of people. The people who have secondary causes, then they have some reason underlying, and it could be genetic, it could be congenital anomalies, it could be valvular, vascular anomalies. The list is like 50 things in there. They're all mostly rare conditions. Some of them have direct treatments for them, so it's not just more blood pressure medicines. Some of them we don't actually have a specific treatment for, so it's just more blood pressure medicine. But yeah, there's about 1 to 3% of people have some explanation, genetics being one of them. I think the 97% is affected by genetics. It's just the genetic impact of any one gene is so small that it's really a constellation of many different variations. And it's just too complicated for us to, I mean, people are trying to do this with research, trying to understand that. But it's so far too complicated for what we know how to do to actually see a treatment that will come from genetic modifications. So not yet. I don't know that I'll still have any hair on my head by the time we get to some answer to that. It's going to take a while. But people are working on it from the research point of view.
Violence, the children in schools are affected with, the situations that they're in, that they have to be fearful, know how to protect themselves, the fight or flight thing. If they're children, they're broken up. I mean, they're not having that serenity and peacefulness as a child. Is that going to affect them as they age?
Yes, it does. And in fact, we know that it starts in the womb. So if the mother's stressed and the mother has high blood pressure themselves, then the babies will end up having more cardiovascular disease, when they grow. As they grow, they'll have more cardiovascular disease, poorer outcomes, and whatnot. That link has already been made. Publications are out with data on that. Yeah, they are. And, pregnant women's hypertension issues are complex, actually. There are like 6 different conditions in that situation, that scenario. They don't get as much attention for research as they ought to. And it's because people haven't really recognized globally that what happens, yeah, exactly, that what happens in the womb of the mother is very important to what happens to people when they're 20, 30, 40, 50 years old of age. That's a new knowledge that we have. And so, yes, it yet hasn't kind of got widespread to putting together strategies and programs. We're actually talking to a clinic right now who's interested in doing that, and we're talking to them about how to use the cellular devices for pregnant women to monitor the blood pressure. But interesting, the concern they brought to us is they're worried that women will actually worry about their blood pressures if they're checking their blood pressures, and it will create more stress in the pregnancy, which is actually, I mean, pregnancy can be, and it is for most people, at times a very happy thing, but at times a very stressful thing. And so we add monitoring to patients that don't need it. I can tell you, my patients, you probably worry about your blood pressure too. My patients in the office who are not pregnant, if I tell them I need a blood pressure every day, they suddenly think there's something bad happening. He's not telling me about it. Something is about to happen. I'm going to get a heart attack. That's why he's worried. He's asking me to do all this. My family, friends don't do that. Why is he asking me? The brain just takes us to places. So they're worried about this. So what we're talking about is now to select a small group of high-risk women who, even if we make them a little stressed, we are still believe we're going to benefit them by knowing this information. And we're going to try to do a pilot with the devices, the cellular devices. So, but yeah, it is recently known that it is very influential what happens from stress and other environmental factors from the very early days.
Graph shows that it's leveling off and going up. You know, environmentally, is
Yeah.
there something?
Yeah, no, yes, and social stress and poverty and disparities are getting bigger and bigger. They were big, and then they got better, and now they're going back again and becoming big again. So some people believe that stopping and perhaps it's starting to go back up may be a reflection of that, the social determinants, the stress levels, because smoking keeps going down. Obesity or weight keeps going up. So other people think it's just the weight is the driver of this blood pressure going up issue. So it's to be determined. Yeah.
Years ago, we had stresses,
Mm-hmm.
but a child more or less protected.
Mm-hmm.
Strong.
Mm-hmm. Yeah. Not anymore. This is the new trauma. Yeah, this is what we're going to deal the next 30 years is the adult traumatized by this. So, yep. All right, well, great. Thank you everyone for the presentation. Yes, I have until 1:27 because then I have to get on a meeting. Yes, age. So what happens, there are a lot of things that are happening with age. Number one, the older you are, the higher the risk of side effects from the medicine. So it's first the do no harm. We invoked a do no harm mandate. So if we think we're going to give somebody who's older a side effect, we allow or tolerate a higher blood pressure because we don't want to give you a medicine that causes you to get dizzy, lightheaded, and fall down, break your hip. That doesn't help anyone. So, so it's a tolerance of the higher blood pressure because of the fear that we're going to cause a side effect. And no doctor wants to write on the chart that, you know, an 82-year-old person who had a blood pressure of 141, they decided to give one more medicine to get them down to 130, and now they fell down, got lightheaded and fell down, broke their hip. You know, we're taught not to ever do that. So we're then start tolerating 140, 145, 150. But that doesn't mean you're safer. That doesn't mean, and so stroke and heart attacks go up as you get to be 80. So essentially, we're tolerating this higher blood pressure at a time where you're on higher risk. So it just gets harder to deal with that as people get older. The other reason it confounded by age is there's this thing called not atherosclerosis, but arteriosclerosis. So slightly different word, where the arteries get stiffer as we get older. And with stiffer arteries, you get this thing called pseudo hypertension, meaning the blood pressure readings appear to be higher than they really are. Centrally in your body, they're higher out here, which gets tricky. It's very hard to diagnose. The other thing is that because they're stiff, you can throw a lot of medicine to people and it doesn't change very much. So it's a really hard situation to treat. So we put them in 3 and 4 and 5 medicines and the blood pressure hasn't really changed. I currently have one patient in that situation. Although today I learned that we finally shifting the curve a little bit for them. So it is a challenge with the fact that the medicines people don't respond to the medicines equally because the stiffness of the arteries have changed. And then there's things that we don't know enough about yet. So I just learned that there is an interaction between blood pressure and depression. And blood pressure and depression. I just learned about this within the last 3 months. So it's brand new to me. And so it's complicated and I still don't know what to say about it. But what I'm trying to say, interaction. They just interact with each other. I don't know yet what to make out of it. So I can't tell you up or down. It's very new stuff. There's some literature stuff. Let me just say that what I'm learning about it challenges all my preconceptions of it. So, but what I'm saying is that there are things we don't even know yet about that interacts with your blood pressure. And so there's still a lot more research and learning we have to do. So, yeah, thank you. Yep, you're welcome.